A very interesting topic today, and we'll be talking about aortic valve echocardiography and aortic valve repairs. And we have got today Dr. Naman Shastri. He's the chief consultant cardiac anesthesiologist and intensivist in Epic Hospital, Ahmedabad. He's a very accomplished person, and he's a member of the research committee of American Society of Echocardiography. And he's a member of the review board of Indian Journal of Pharmacology, and he's also a member of the review board of Annulus of Cardiac Anesthesia, and he's the director of the fellowship in cardiac anesthesia, Epic Hospital, Ahmedabad. We are all looking forward to your pearls of wisdom today, and we are looking forward to learning a lot from you. Over to Dr. Naman. Thank you.
Thank you very much, sir, and good morning. Hello, everyone. First of all, I thank you for sparing a valuable time on the Monday or on the Sunday morning. In a fearful atmosphere outside, I wish everyone to stay home, stay safe, and God bless you all. I thank Dr. Prasanna Sinha, sir, for sparing a valuable time. Sir is a very leading figure in field of the repairs. He also does and teach transesophageal echocardiography, cardiopulmonary bypass, means a person with a complete package of cardiac surgery and cardiology. And I thank Philips for making this lockdown period very fruitful by releasing quite number of good eco series programs by the stalwarts, and I'm feeling happy to be a part of these programs. So, as again, in interest of time, we would go for the presentation. The presentation is echocardiography of aortic valve for suitability of repair. We do quite number of 3D echocardiography, so my many slides will be having the accompanying the 3D echocardiography images, but that does not mean that we can't manage aortic valve repair programs without 3D echo, but it makes our life very easy, and Philips is one of the leader in 3D echo machines. My name is Dr. Naman Shastri. I'm from Epic Hospital, Ahmedabad. Any repair programs or cardiac surgical program cannot exist without having the fantastic team with us. We have on the right top, we have the group of anesthesiologists who are mastered in cardiac anesthesia and intensive care unit. And people behind this aortic valve repair program, the surgeons, Dr. Anil Jain, Dr. Srinivas, Dr. Vishal, Dr. Rajan, and all the surgical group, they are the fantastic human being, good surgical people, skillful people. Because of them, our aortic valve repair program particularly has made it possible at this stage. So I really thank all the surgical team for believing us, because when we talk about the repair program and assessments, it is very important that you believe your colleagues, and they completely believe whatever presentations on the echo images inside the operation theaters. Now, before starting the aortic valve repair, it is very important to understand the aortic cusp, annulus, subcommissural triangles, sinotubular junctions, and unless and until we are able to understand the functional interactions between these components of the aortic root, it is very difficult. And since a couple of decades, this program is improving, but previously it has been big failure. And the reason behind it is there were many attempts has been done to repair the valve, thick aortic valve, calcific rheumatic valve, because in India there are a lot of rheumatic patients coming up, and this recurrence rate has made things difficult to repair the valve. The result of European Heart Survey has shown that if we talk about the bicuspid aortic valve repair is still underused and performed in nearly less than 2% of the cases. So most of the people are not being offered these techniques, and the main reason is that we need to demonstrate the standardized pre-pump intraoperative echocardiography and pre-operative echo protocols. And that protocols is very well established for the mitral valve, but yet not established for the aortic valve. So basically, we need to start understanding the functional aortic annulus, and most of us are well aware about it. It's a very nice crown-shaped aortic cusp with the commissures, with the intercommissures triangle, the very nice sinuses, and ventricular aortic junctions, which is a surgical annulus. And on 3D echocardiography, we can visualize very well. Very important thing is when we talk about the cusp, cusp are hanging from the sinotubular junctions, like with the commissures. So the cuspal attachment is not only at the level of annulus, but they are also extending up to the level of sinotubular junction. And we know how to measure the annulus, but it is very important at what level and how you measure the annulus. So basic components of roots, sinotubular junction, sinuses, and the basal attachment of aortic cusp. And this assessment is very important when we are looking at the aortic valve repair programs. Now for the aortic root, you can in 3D echocardiography, you can see very nice leaflets, sinuses, sinotubular junctions, complete annulus. And you can see that the commissures are attached to the level of sinotubular junction. So once you are well versed with it, then your life becomes more easy. So greater understanding of the relationship between the aortic valve and part of the root has made our aortic valve repair program much developed after 1980s. And we all know that the advantage of the repairs are much more as compared to the replacement, because in one research study shown that whatever you do replacement with the bioprosthetic or mechanical valve, the outcome after the 10 years is very grave and it declines very fast. So the avoiding thromboembolism, endocarditis, bleeding, structural valvular deteriorations, all these things are much problem like prosthetic valve dysfunctions there in the aortic valve because it is high pressure jet area. We have CTCMR, but since the topic is more to the echo, we did not touch this issue. So when we start in the perioperative, which is transesophageal echocardiography, it is very much identical with the transthoracic echocardiography. But when we talk about transesophageal, there are 4 views, and to make people life easy, how we can distribute these 4 views. The 2 views, which are the mid-esophageal short axis and long axis view, are meant to analyze the structural problem of the aortic valve, and that is very important. And the last 2 views, which are the transgastric views, they are meant to assess the Doppler analysis of the aortic valve. So very important for us to understand is the structural analysis, and that is so mid-esophageal 2 views, the short axis and long axis views are very important. So if you look at the short axis view, this is very common, well accepted views and very well known by every surgeons and cardiologists for the transesophageal. You can see here the very good Mercedes-Benz kind of signs where the bottom is right coronary cusp, the one which is next to interatrial septum is non-coronary cusp, and other is left coronary cusp. And you can, if you look at the 3D, you can see very well views of all the 3 cusps where the bottom is always RCC, because when you look at the echo in transesophageal echocardiography, the bottom is always an anterior part of the images. So this is RCC, this is NCC, which is next to interatrial septum, and other is LCC. Here, when you image the long axis view, mid-esophageal long axis view, very important to take a sample image in a proper plane, because you can see in some images, you can see there is a prolapsing of a cup, it looks like. So the proper plane of opening and closing of the both leaflets are important. Otherwise, it looks like a prolapse, but it is not. And another important aspect is the lower cusp is always right coronary cusp, and the top one can be a NCC or LCC. So this is the second view, which is very important, mid-esophageal long axis view for us to understand the structural analysis. So this is a standard view of 3D from the aortic aspects. We can see the right coronary cusp, non-coronary cusp, and left coronary cusp. And if the advantage of 3D is, if you look at it from the left ventricle side, LVOT side, also you can see that the non-coronary, right coronary cusp at the bottom, and non-NCC, non-coronary and left coronary cusp. But when the surgeon is there, if we have a 3D echocardiography, we have to orient the surgical view where the 45-degree of counterclock rotations makes RCC on the anterior part here on the right top. The LCC becomes the left top, and the bottom is the NCC, which is the most posteriorly. So it becomes very easy for the surgeon to understand the surgical view by just counterclock rotations of the aortic valve. Here you can see the coronary artery also, but again, I would not go much into detail about assessing the coronary artery. So the T assessment is like what we do routinely for all the patients, is what we do it. I think it is again. Is it okay? Am I audible?
Yes, sir.
Yeah.
Yes.
So what we are looking for, exactly quantifications what we do in a transthoracic in preoperatively. So in perioperative, intraoperative, we are not much concerned about the quantification AR because it has already been diagnosed. So very, very important is to go with the structure analysis. So we will skip that assessment part. We believe that all patients who are referred for the aortic repair has got moderate plus aortic regurgitations. So what do we look for? We look for the Cusp numbers. We look for the valvular calcifications, valve orifice. We look for the aortic crook assessments, maybe having the post-stenotic dilatations, or we can say we have to look at the other valvular, particularly the mitral valve annular calcifications and aortomitral continuity. Because if this is a significant calcific valve, then the structural analysis shows that the repair is less likely. So the important parts to assess the root and leaflets. So when we look at the cusp, we can have the tricuspid valve, we can have the bicuspid valve, we can have the quadricuspid valve, and we can have the unicuspid or monocuspid valve. So to surprise us, as the statistics shade that about 2% of the human they have the bicuspid valve, which remains unnoticed. We have in our practice, we have seen a quite number of the quadricuspid valve also, which we have replaced or repaired, and the monocuspid valve, which is looking by the eccentric opening. So it is again important to identify the cuspal anatomies and the number of cusps. So when we say the monocuspid valve means usually the orifice is at the eccentric orifice, where you can see only the one part of the commissure which is open, other commissure are not seen at all. So there is only one commissure which is opening of aortic valve, and the rest of the commissure are absent. Now we had come across the recently two quadricuspid valve in one patient. They had 4 valves, 4 leaflets, but he also had the sinus of valsal valve rupture. So in this case, we did the sinus repair as well as aortic valve replacement. But this is a young female, a young lady, rather I would say girl, 15 years of age, with the quadricuspid valve where we have repaired this valve. So the quadricuspid valve also has been seen by us quite couple of times. Now, when we talk about aortic valve, it is not a disease of the aortic valve itself. It is basically the aortopathy. We know that when we talk about the mitral valve is a part of left ventricle. Rather in aortic valve, it is a part of the aorta. So when there is an abnormalities, the structural congenital anomalies like bicuspid and tricuspid or bicuspid and monocuspid or quadricuspid, it is basically an aortopathy. So basically we can't exclude the aorta when we talk about the aortic valve. We can see on the left top is a tricuspid valve, but the middle is a bicuspid valve. Now when we talk about the bicuspid valve, it is not only easy to say that, okay, maybe it is a bicuspid valve. You have to categorize exactly what type of bicuspid valve is this. Where you look the raphe, which is raphe is dense opposite to each other. When the commissures are dense opposite to each other and there is an absence of raphe, means there is 0 raphe, so it is called type 0 bicuspid valve. When you have the 1 raphe, then what happens that 2 commissures are formed, but the another commissures are replaced with the raphe that is called malfunctioning or underdeveloped commissure, that is the raphe. So the things becomes 1 raphe. So we can say this is a bicuspid valve with the 1 raphe or type 1 bicuspid valve because it is a 1 raphe. So no raphe is bicuspid valve type 0. 1 raphe means the bicuspid valve with type 1. When we talk about the unicuspid valve, means both the commissures are absent, only 1 commissure are present. But remember that we cannot stamp as a bicuspid valve type 2. It should be considered as a unicuspid valve. Now, if you look at the bicuspid valve phenotypes, as I said, it is aortopathies and it is a congenital anomalies. There are many principles have shown why this has happened. They usually, as compared to the type A, which is normal tricuspid aortic valve, V, which is because of the fusion of the right coronary and left coronary cusp fusion, and this is a very common fusion. Nearly 80% of the bicuspid valve is because of the fusion. So here we can say that there is a one raphe and there is a fusion because there is a fusion between the RCC and LCC. So how do we categorize this? It is the bicuspid aortic valve type 1 because there is a one raphe by the fusion of LCC and RCC. So it is the bicuspid aortic valve with the type 1, and since it is a fusion of LCC and RCC, we can call it bicuspid valve with the type 1 LR type. LR type means fusion of the left and right coronary cusp. Type 2 bicuspid aortic valve, the fusion of RCC and NCC is very less as compared to the fusion of LR, but it can be named as bicuspid aortic valve. Again, fusion, so type 1, one raphe is type 1, so bicuspid aortic valve with the type 1 and NR type when there is a fusion of the NCC and RCC, and very less likely and very few cases we have seen in the literature of a fusion of the NCC and LCC. Now, in bicuspid aortic valve, it is very important that we understand the pathophysiology and anatomical structure analysis because the results have shown that bicuspid valve is more favorable for repair because there is only single coaptation line appears to be contributed, increase the chances of repairability. So our surgeons are more tempted when they see the bicuspid valve and provided they have explained which type of bicuspid valve is there. So the commissures are basically, commissures are when becomes a mal-defined or when they are ill-defined, they are become the raphe. Now, when we talk about the surgeons, it is very important to say how, as I said, bicuspid type 0 or 1 or type 1 then LR or NR type. And another important thing is to categorize the commissure orientations. Now, in these cases, you can see that this is a very common fusion is left and right coronary cusp. You can see here the raphe, and you can see the non-coronary cusp is unfused cuff, and this is an independent cusp. So here you can see the commissures are just densely opposite to each other. So this is a 180 degree of the commissures we can see here, and the angle you measure where the non-fused cusp is there. So in the direction of say non-coronary cusp, we measure the angle and we can say that it is a 180 degree, that is a symmetrical configuration. So how do you categorize this? Bicuspid aortic valve with a type 1 because one raphe with LR type, this is left and right coronary cusp fusion, and it is a symmetrical origin. So you can, if you tell surgeon, then surgeon orients very well what he is dealing with. So raphe is very important, and you in the long-standing aortic regurgitation because of the aortic valve, sometimes the raphe is separated, and on transthoracic echocardiography it looks like the third commissures, but it is very important you see the raphe very important. When we talk about unicuspid valve, it has fully developed one commissures and two raphes, but it should never be considered as a bicuspid aortic valve. Like you can see the difference between this monocuspid and bicuspid. Now, when we talk about the annulus, it is very important how you measure the annulus. Usually we measure from the joint hinge point to hinge point of the aortic valve. But again, an important thing, when you measure in the long axis view, we are not sure whether we are passing our line of cursor from the commissure to the sinuses. When we talk about the annulus, when we measure the annulus diameter, that has to be passing from one commissure to the sinus opposing to the commissure. We never pass to the commissure to commissure. So it is very important that you see, if you have a biplane view, like if you have here, like you have 3D echo machines, on the left reference point, your cursor is passing to the commissure to the opposite sinus. That time the biplane view is exactly passing the right commissure, the right plane, and we can measure that annulus. Otherwise, what it is said that when you have the two very nicely formed sinuses are seen, means you are not passing to the right plane. So basically, another very simplistic way in the 2D echocardiography, when you don't have a 3D echocardiography, you have to have the one cusp which is seen very nicely, but both, when you see the both cusp very nicely, means you're passing best. Now, there are different software available with the advanced eco machines for multiplanar assessments for the annulus, where I don't go much into detail, but they and Tomtec technology, which is acquired by the Philips now, even they can measure the annulus very well, and that is more useful in the procedures like a TAVR and other invasive procedures, but I won't go much into detail. So these are the aorta linear segments, the sinuses of Valsalva, and everyone knows about the normal diameter of all these linear segments. Sinus is, if it is more than 4, sinotubular junction is more than 3.5, or the proximal ascending aorta more than 3.8, that indicates in man that it is a dilated. Now, apart from having the basic ideas about the cusp and the sinuses, very important, like in mitral analysis, we also go very depth into the aortic root measurements. And we have gone to the annulus. So now beyond the annulus, there are very important parameters you should see when you see in a valve. That is, first of all, is a geometric height. Geometric height of the cusp is starting from the nadir, the coaptation surface, and from coaptation to entire coaptation complete, this free line is called a geometric height. And geometric height indicates the complete length of the cusp. And this cusp length is very important to explain to the surgeon whether he has enough tissue of the cusp for the repair or not. And the ideal height of the ideal geometric height for any valve is 16 millimeter. And when we talk about the bicuspid valve, it is 19 millimeter. I'll come later on. Second height, important height, is effective height. That was a geometric height. This is the effective height, means from the annulus to the tip of the coaptation, the complete effective height means where the coaptation ends, and that decides whether they have the enough space for the room for the leaflets, availability for the repair or not. And the ideal height of this effective height from the annulus to the tip of the coaptation is 9 millimeter. Another third point is the coaptation height. It is the length of the coaptation area, that is a namaste part, where it is if it is more than 4 millimeter, then we can say that the coaptation height is very important. So coaptation height is very important in post-operative repair assessments, whether the coaptation of annulus is good or not. Even that will come later on. So when we start about the effective height, so when we want to measure the prolapsing leaflets, that time effective height is important. The retracted, the restricted leaflet, the geometric height is important. I will just show you how. So the prolapsing leaflet by the effective height is about 9 to 10 millimeters, as we said. So here you can see the prolapse leaflet is there, and can be easily seen that you can see very eccentric aortic regurgitations. In short axis, you cannot exactly define where the prolapse is, but in long axis, we can see the prolapse is clearly seen, and you can see the eccentric aortic regurgitation going, which is going towards the mitral valve. So when you have the jet going towards the mitral valve, towards the base, means it is going posteriorly. So the anterior cusp, that is a right coronary cusp, is prolapsing. So jet is going in opposite direction, that is a mitral valve. So this is the effective height. Now so when you have the from annulus to distance of a tip, when you have this height less than 6 millimeter, then we can say that is a significant prolapse. So here in this case, I will show you, you can see, if you can see that the right coronary cusp is prolapsing completely, it's nearly the flailing leaflets. You can see it is directly protruding into the LVOT, and you can see a dense eccentric aortic jet going on. And these aortic joints, if you put the cursor line from the annulus, the portion of the RCC is just heading towards the LVOT. So what will you get here? Here you will have the negative effective height. So if it is a negative effective height, means instead of into the aortic root, if the leaflets parts is completely protruding into the LVOT, it is for the complete prolapse, or we can say effective height. But in the complete prolapse or the flail leaflets, In the complete or flail leaflets, you have negative prolapse, negative effective height. Now, in case of retracted cusp leaflet by geometric height, as I said, the prolapsing height is for the prolapsing leaflets, it is effective height. For the retracted leaflet, it is a geometric height. The geometric height is a total cuspal height available for the surgeons for the measurement. So what they do it intraoperatively, they have the caliper. The caliper, the Schaefer has defined very nice caliper. So they just put a caliper into it, into the aortic root, and they measure the complete geometric height. And the geometric height is measured from the nadir, from the hinge point to the coaptation surface, and from the coaptation surface to the coaptation line. And it is 16 millimeter, which is for the tricuspid valve, and 19 millimeter for the bicuspid valve. If it is less than that, that is usually happen into the bicuspid aortic valve. It may happen in the rheumatic pathologies. Then we can say that this is not the adequate size of the tissues. Even I have heard the lectures of Dr. Schaefer. He's a fatherly figure of the aortic valve repair. He has said that do not try to attempt if the geometric height is less than 13, 14, because then you will not have adequate cusp. So here you can see the square calcific aortic valve. This is what we are measuring the retracted. You can see the retracted aortic cusp. This is the height for the geometric height, addition of these cusp coaptation to the complete coaptation point and measure it. Now you have to, going ahead, you have to measure the valvular morphology and calcifications. Like Wilkinson's classifications we have in the mitral valve, it is really nearly the same, but they have committed only to the leaflets. When there is a no calcifications, it is grade 1. If it is a mild calcification, with small isolated spot, and that we see many of the time in the degenerative calcifications, then we can say that there is a mild calcifications. But when we have the moderate calcification, where multiple large spots of the calcium is seen, or if it is heavily calcified, then we can say that then it is a grade 4. So here in this case, you can see it is a grade 3 or grade 4, where there are the multiple spots of the calcium are seen on the leaflets, and you can see there are significant restrictions and calcification score, and this is more than moderate 3. And so it is more the calcifications, the long-term success of the aortic repair is not accepted. So when you proceed for the aortic repair, it should be less than 3. There should not be a big long calcification, moderate size of calcification nodules on the leaflets. So cuspal thickening is defined as when the thickness of the leaflet is more than 2 millimeter on either cusp, then we should consider that this is a cusp is thickening. And when the cusp is more than 2 millimeters, then we can say that this cusp has to be retracted. There cannot be normal movement. Now, after assessing this, it is very important now to assess the regurgitation. Is it for the repair or not? So the pre-operative, not pre-operative, rather I would say pre-cardiopulmonary bypass, it is very important to assess completely the quantification and the structure analysis. So the important aspect is again not only quantifications, the mechanism lies behind it, whether it is the leaflets or ascending route is the problem. So when we talk about the assessment in intraoperatively, again the Doppler analysis. Now after structural analysis for the Doppler assessments, the transgastric long axis view, where you can see the very Doppler assessments, and these when you assess these view, it is also important view in the post-repair assessment as well. So two transgastric view are assessed to see the quantifications of the regurgitation. One is transgastric long axis view, and this is the deep transgastric view, where you have the complete aorta on the long axis view at the deep transgastric view, and you can see very nice Doppler to this. Now, functional classification is exactly same as with mitral valve given by Carpenter classifications, and these are the type 1, like in the mitral valve, where the mitral valve annulus dilatations, but the leaflets movements are normal, it is type 1. Same here in the aorta, in the presence of an aortic annular dilatations, but the cusp is normal. leaflet movement is normal. Type 2 is redundant leaflets, means hyperdynamic leaflets, that is type 2. And type 3 is a restricted leaflets, where we see the rheumatic pathologies and the bicuspid aortic valve pathologies. So basically in type 1, usually we have the central ARZ. In type 2, since it is a hyperdynamics, 1 or 2 cusp, which is hyperdynamic, it is eccentric AR. So when you see the eccentric AR, the more likely is a type 2 pathology. And type 3 pathology, when there is a restricted cusp, there may be in a rheumatic pathology, usually you have this large central AR, because all the 3 cusps are involved into the restrictions, and you will have the non-coapting zone in between. So these are the 3 mechanisms: type 1 central AR, type 2 eccentric AR with the cusp prolapse, and type 3 usually large volume of central AR in case of the cusp retractions. Now, Al-Khoury is a big name into the classifications of the aortic regurgitations, and he has refined the classifications in a way to understand the aortic root involvement into the aortic regurgitation, and that is very important. We can't just look at the leaflet, we have to assess the ascending aorta as well, because we know that the aortic valve issues is usually associated with the aortopathies. So echocardiographic descriptions of the Al-Khoury's classifications is in type 1, type 2, type 3, same as other classifications, but type 1 has been defined and has been given additional importance by subtypes that will explain on the basis of the aortopathies. So when person has a normal aortic diameter, normal aorta, patient can have the isolated AR, and that is usually seen in the rheumatic patients when the aortic root is usually normal. When you have this dilated sinus of Basalva, this is a root dilatation. So this is a second phenotype, second pathology, aortopathies, where you have the root dilatation, but ascending aorta remains normal. The third is ascending aorta and root both combined dilated, or maybe the root may be normal and only ascending aorta may be dilated. So there are the 3 different phenotypes of the aortopathies are seen. On that basis, Al-Khoury has given the classifications. Type 1 has given additional subclinic. Type 1 is when there is a dilatation of ST junction beyond ascending aorta, where the root remains stable. Root is not dilated beyond STJ. Dilatation is group 1A. Group 1B means root is also dilated. So ascending aorta has also dilated the sinuses. There is a 1B. 1C means it is a dilated annulus part. Only annulus, maybe with sinus of ST junctions, root, aorta, which has dilated the annulus, or there may be a very less chances that may be only aortic. There may be only the aortic annulus which is dilated. That can be there in patient with associated other pathologies. Type 1D is perforations. There is a perforation in the aortic leaflets, maybe because of the vegetation or that, but aortic annulus, in all these 4 categories, the leaflets movement should be normal. So when there is a perforation, but leaflet movements are normal, they are in 1D. But when there is a perforation because of the vegetations, they fall into the type 2, that is cusp prolapse, and type 3 is a cusp restrictions. So if I go one by one, it is a type 1. This is ST junctions dilated. You can see in the bottom line, first figure left, right, where you can see the dilated ascending aorta, but the root is nearly the normal. You have the central directed jet. Type 1B is you have the even dilatations of the. You have even type 1B is even dilatation of the root also, and type 3 is dilatation of the annulus, aortic annulus. So these are the 3, 1A, B, C. When we talk about the type 1D, this type 1D is a perforation in the aortic valve. But again, leaf is normal. That's what we can see. Here you can see in the right image, there is a perforation in the aortic cusp. So this is type 1D where you have the vegetations. Now let's correlate with the surgical aspects. When we say dilatation of the functional aortic annulus type 1A, here what we can say that That is basically a root has to be preserved. The root size, the sinus is usually normal, but you have the complete dilatations beyond the root. You can see the ascending aorta is dilated. That is there in these phenotypes. It is aortopathies. It is because of the only ascending aorta aneurysm. And these ascending aorta aneurysms, when it develops aortic regurgitation, that it has impacted the root, but otherwise only these part is involved, that is ascending aorta. Now, if only the root is involved, only these part, ascending aorta is involved, then why should we bother for root? We should only replace it with the graft, that is interposition graft, where it starts from the sinotubular junction to the complete annular part. Because root is normal, we don't need to touch the aortic leaflet, annulus, the sinuses, sinotubular junction, but ascending aortic aneurysm is replaced with particularly the graft, and these graft can serve the purpose very well in place of the aneurysm of aorta. Nowadays, the subcommissure angioplasty is not done because it remains unstable, and then chances of recurrence are very high since it is old videos where the subcommissure angioplasty is done. But here you can see that a complete patient has its own aorta, but the root part is replaced with the interposition graft. So it is only correction of the ascending aortic aneurysm. Now, if patient has got associated moderate plus AR or more than mild AR, then the surgeons may take additional aneurysmal sutures to make it more in favor of annuloplasty. So what we measured? We measure the complete ascending aorta, because here you can see this root is normal. You look at the bicuspid aortic valve, and why again, I missed one point, why we don't need to give the typing of a bicuspid aortic valve. So as I said, most commonly is left and right fusion of a bicuspid valve, that is type 1 in the cuspal orientations. So in this way, these are the leaflets, these are the orientation of a cusp that affects the aortic root. If you have the left and right cusp which is fused, that will dilate the root. But if you have non-cusp and right coronary cusp which is fused, it will go and affect the directly ascending aorta and the descending aorta part also. So when you have the LR, always look LR combinations, then always look for the root. So you have to remember LR means root. When you have a combination of right and non, then you should look at the ascending aorta and descending aorta also. Because the reason behind it is the velocity which is being thrown by the left ventricle with this bicuspid valve, it goes according to the configuration of the cuspal design. So here when we say about the aortopathies, when we say about aortic valve repair, our assessment doesn't end at the aortic root, but we have to assess ascending aorta, we have to have a short axis view, we have to look at the arch, the dilatation of the arch, and we have to look for the complete ascending and descending aorta, because there can be associated other pathologies. So these are completely aortic assessment is very important in this view. Now from 1A, which we replaced only with the interposition graft, we did not touch with it, but now the dilatation is extended up to the sinotubular junctions, and now the aortic root is also increased, and this is well commonly seen in patients of Marfan's, Ehlers-Danlos syndrome, patients of the bicuspid aortic valve. So here the dilatation of the aortic root, the dilatation of the aortic root means STJ has dilated, and it has dilated the complete root along with an annulus. Because as I said, annulus is part of the aortic valve, that is the aorta, that is aortic root. So when the root is dilated, annulus automatically gets dilated. So there is a place of non-coaptating area in between. So here you can see that completely root is dilated. It is large central AR. But so here you can see that when you have aortic annulus with a non-coaptating zone, then it suggests that aortic annulus is definitely dilated. So here you can see in 3D echocardiography, this is a bicuspid aortic valve, again LR type. You can see this is a non-coaptating zone, and this non-coaptating zone means it has to have a dilatation of the aortic root. So this appears more in the Marfan's, Ehlers-Danlos syndromes, bicuspid aortic valve, and in these pathologies, increased aortic stroke volume that leads to the completely further dilatation of this aortopathies. So once patient falls into this category, means once patients start developing the root dilatations, the aorta keeps on dilating further and further, and aneurysm can progress from the ascending aorta to the arch also when they come in the later stage. So in Marfan, many of the times we have seen that even the root part is involved. So here you can see that this is a non-coapting zone. This is a completely directly non-coapting cusp you can see here, and you can see the bicuspid wall of the same patient. And this is again very common in the late comers of the bicuspid aortic wall. So the pre-repair, as I said, complete analysis of the root, annulus, the cuspal height, effective height, the geometric height, root size, the ascending aorta size, region of the bicuspid aortic wall, and very important when we talk about the degenerative, calcific, or the long-standing bicuspid wall. Sometimes we have seen the calcifications on the wall of the aortic root as well. So this is very important when you are repairing the aortic wall, how is the root calcification. Here on the 3D, you can see that some small calcific plaques which is seen in the aortic wall also. So wall of the aortic root and the ascending aorta is also important. So usually people fall into the Bantal procedures, but recently when you see the wall leaflets are totally intact, they have the adequate geometric and effective height, then why not to go for the aortic wall sparing roots replacement? And there's two important procedures being followed now, and our surgeon group of surgeons are doing root remodeling, and they have got very good results, and I'm very happy to share that we have more than 80 to 100, maybe more than that, cases where we had done the successful aortic wall sparing root replacements by the root remodeling. So in surgical techniques, if we say the root implant, one of them is root implantations. Now, when you have associated aortic root dilatation and ascending aorta dilatation both together, so what is root implantation techniques, which is formed by the Tyrone David from Canada. He has number of studies behind it. What he does is he puts completely graft into the annulus level, and he puts all the annulus and the leaflets into the graft. So once he puts a graft into the whole complete, this the Valsalva graft or the Gore-Tex graft, these grafts take away the complete leaflets and annulus into the graft. So the advantage is it will stabilize the annulus very well. So this is the techniques by the Tyrone David, and what we do, that this is the Valsalva graft, and this graft has got its preformed sinuses, but we usually do the remodeling techniques, which I'll come later on. So in reimplantation techniques, again, I won't go much into the surgical aspects, but reimplantation techniques, the graft is totally encircled into the annulus and taken away the complete part of the aortic annulus with it, so that it maintains the aortic annulus very much stabilized into it. Root remodeling, this is what we are doing routinely. What we do is the graft, again we put it, and we put up to the level of 3 mm down to the sinotubular junction. Just so we maintain some part of the sinotubular junction, we maintain some part of the root, and then addition to it, we just, and then they put a fenestrate, they put a sections into the sinuses, and they attach directly graft into the sinuses, and they do additional commissuroplasty by the techniques derived by the Schaefer. Schaefer is very good, very big name into aortic wall repair, and it is said that more than 80–90% of the patients he repaired in such cases. So what Schaefer has developed, the complete commissurotomy along with the graft, and this remodeling technique has given us very good results. And there are some cases and some surgeons who are using the annuloplasty ring, like in the mitral ring, but in India we don't have that aortic ring available. So when we have the dilated aortic root, when you have the dilated ascending aorta, then either we go for the aortic wall sparing, root replacements, either root implantations or remodeling, or we can go for the standard Bantal procedure. The problem lies is the coronary anatomy and coronary arteries, which has to be implanted into the graft. The chances of bleeding is very high. When you do the Bental, usually person get the metallic prosthesis, and the lifetime anticoagulations is a big headache. So the post repair in such cases, we can see if it is a bicuspid aortic valve, you can see that in bicuspid aortic valve, we have here patient was tricuspid aortic valve, but since the one of the two cusps we have joined together from tricuspid, we have made it bicuspid. As I said, that if patient has a bicuspid aortic valve, when there is a single coaptation, then the repair program becomes very easy. So here you can say that from tricuspid we have made it a bicuspid valve, and another good non-coronary cusp is fused very well, and then you have very good acceptable repair in the post-operative period. Now this was another case we had where we did root remodeling. You can see the non-coapting ascending aorta from the short axis view. Here you can see the large non-coapting color flow in the short axis view, and these patients, while came off bypass, we could see the two jets going into the assessments. One is going towards the mitral leaflets, and one is going to central aortic valve. That which we discussed with the surgeons. The surgeon find that when there is an eccentric AR jet, it means there has to be cusp which could be either retracted or the prolapse. So they had gone on bypass again, and at least the one which was eccentric jet, which was repaired by taking the suture onto the leaflet. They may increase the leaflet height, which I'll just come a later stage. So by changing the leaflet anatomy or leaflet height, by placating the surface of the leaflets, they increase the leaflet height and the leaflet at one stage that I will just take a later stage. Now type 1D is because of the vegetations and perforation, but remember that we have to have the normal aortic valve leaflets movements. Now when we talk about the vegetation or perforation on the aortic valve, we also need to see the mitral valve, because the vegetation can hang and have the hissing lesions on the aortic leaflets. So associated other valve has to be seen, which I'll just take it later on. So in the vegetations, we have many times a very bad vegetation seen in our practice. Like you have the aortic root abscess here. Here you can see very well in the lower bottom screen. The aortic root abscess is seen, and these valve, with whatever the anatomy of the cup, should never be attempted for the repair, because the aortic root per se is very big, and that's commonly seen in the bicuspid aortic valve, long-standing, and patient has a vegetation. So these kind of leaflets should never be thought for the repair. Another one case with the vegetations, this is a bicuspid valve. Now this bicuspid valve has the left cusp and the right cusp. So the left cusp is having the big vegetations on it, and this right cusp, the another cusp is spared, but since one cusp is totally destroyed, like since what is seen here, then this cusp should not be or ever tried for the repair when it is totally restricted, because this cusp has two problems. Either the root abscess or associated other valve problems lies also there. Now, the previous case, when we look at the other valve, you can see here in 3D, the vegetation is hitting towards the anterior mitral leaflets. Here you can see that it is hitting to the anterior mitral leaflet, means the vegetation is hitting on the anterior mitral leaflets. That has produced a hole into the anterior mitral leaflets. So what we did in this case, we replaced the aortic valve, but we had to put the patch on the anterior mitral leaflet. So when you have the vegetations and perforations of aortic valve, the associated other valvular leaflets is also very important to be seen. So the type 2, which is a prolapse, and when we talk about the prolapsing leaflets, it is very important we think about effective height. And this effective height is very well important, because that is important height to express to the surgeons to give them which degree, what degree of the prolapse is there. Here you can say very important hallmark of the replace for the prolapse is it is an eccentric AR. So when you have the eccentric AR, always find one leaflet which could be restricted, or other leaflet which could be the prolapse or the excess tissue. So here the mechanism lies of the aortic valve for the type to prolapse is very important. What is the reasons? Like cusp prolapse can be further categorized in the 3 subtypes: partial cup prolapse, whole cups prolapse, and the flail cups. And that, I say, depends upon the effective height. If the effective height is negative, as I said, if it is less than 0, means it is a partial, it is a complete prolapse, or we can say that it is a flail leaflets. If it is between the 0 to 6, we can say that it is the partial prolapse. Sometimes we can see the 1 or more leaflets which is prolapsed into the LVOT because of either excessive tissues or commissure disruptions. So when you have the prolapse, when you have the eccentric AR, our aim of assessing the aortic leaflets becomes more important to check it, which is a retracted leaflet, which is a prolapsing leaflet, or one leaflet which is prolapsed, or the both leaflets are prolapsed. So many of the times we are not sure how the regurgitant jet is given. You put the M mode and you can see this is an eccentric regurgitation seen here. On the M mode, we can see that whether the leakage is from the eccentric area or which is in the center. So the type depends upon where the leaflets, where the regurgitation jet is going. In some cases, eccentric AR jet is visualized without obvious evidence of cusp prolapse. In these situations, the pathology may be fenestrations or small tear along the free margin of the cusp. So basically that falls into the 1D categories, where it is not because of the vegetations. The leaflet movements may be okay, or you can say that with the leaflet movements okay, with the jet is eccentric, always look for the fenestrations, or we can go to look at the tear. So when you have eccentric jet, 3 things important: restricted leaflet, prolapsing leaflet, or if you have 1 leaflet which is prolapsed, or the 2 leaflet which is prolapsed, or there is a fenestrations or not. Now in this case, we had the RCC. This is the right coronary cusp which was prolapsing. You can see the very small RCC, and when you see here the 2D echocardiography, you can see when you have the prolapsing cusp, you will see the ring type of appearance of the cusp into the short axis view. Here you can see the just small rings type of the cusp which is prolapsing, because that cusp is not seen in that particular section. So if you put a color flow, this is a large flow which is going to the commissures as well as from the central area, and you can see that this is from the LVOT aspects, and you can see this right coronary cusp is prolapsing into the LVOT. On the biplane mode, you can see here the right coronary cusp is totally sagging into the LVOT, whether the LCC or NCC looks normal. So this is only the 1 cusp which is prolapsed. This is what we can say the sagging leaflet. We can say the prolapsing leaflet, and this leaflet is with, so this is only 1 single leaflet. The rest of the root looks reasonably okay. So in this case, the repair is definitely well accepted. So in this case, we did the repair. You can see here we did not put any graft, but here what they did is, since it was a short in structure of the right coronary cusp, they did the plication of the right coronary cusp and they increases the height. So the surgeon increases the height. So we convey to the surgeon that only right coronary cusp, which is sagging or which is prolapsing, has the height of, that is the geometric height of the cusp is this much. So when we measure the geometric height, we have to measure geometric height of every single cusp. When we measure the effective height, that is only 1 single effective height. So when you measure the geometric height, the entire cuspal height should be measured. So we can see that the geometric height of the non-coronary cusp is about 17-18, about the left coronary cusp is about 17 plus, but you have right coronary cusp with only 14 size of the geometric height, and it can be increased later on. In 3D echocardiography, you can see very nice, well increased height of the right coronary cusp. If we have the quadricuspid aortic valve, here you can see this was a 15-year-old lady. This 15-year-old girl who has a quadricuspid valve came to the hospitals, and our aim was to repair in these patients. So you can see in the 3D very well the four quad cusps. And very important to say that whenever you have the quad cusp, there is definitely defect in the commissure. All commissures normal in the quadricusp valve. So here you can say the right coronary cusp is divided into the 2 cusps. One is the right the right cusp to the right side and the right cusp to the left side. And you can see the small piece of the raphe in between. So this is definitely the aortic wall abnormalities. You can see very well color flow into that particularly open segments. If I do the zoom, you can see the very well retracted aortic wall. But in this case, what we did is we have made sections of these two bifurcated aortic cusps and made a single aortic cusp, and you can see the very nice opening and closing and coaptation. And these mild AR is well accepted at the 15 years of age of patients, and this has made patients like very best as compared to the prosthetic wall. You can see they have the very nice coaptation in this part with a very mild aortic regurgitations. So this is what we have seen of that case. Now post repair, you can see this is a post repair patient, the same at the time of coming of bypass with this patient has mild to moderate AR, but you can look at the rhythm is not stable. One patient has adequate time of rewarming and the rhythm becomes stable, patient regurgitation jet has come down. And this is the post repair. Now type 3 is because of the cuspal restrictions, and that's usually seen in the rheumatic pathology, or this is maybe seen in the eccentric aortic, or that is the monocuspid aortic wall. You have this very common. Here what you see, there is a systolic doming present. So it is in the center of the aorta. You can see the systolic doming, the concavity towards the center of the aorta is seen, and that suggests the cusp is restricted or restricted movements. Though the movements are normal, but you can see that there is a concavity in the central aorta, and that suggests that patient has got restricted leaflets. And very important in rheumatic is aortic root size is normal. So when you have the central opening with aortic root size is normal, it is not because of the ascending aorta dilatations. So this is usually because of the rheumatic side, rheumatic pathology, and you can see the everted calcific aortic leaflets. This is one interesting case we had. This patient who came to us for the aortic wall, mitral valve replacements. In perioperative period, we noticed patient had more than moderate aortic regurgitation. You can see that jet is going to the left ventricle. What we noticed that there is a fusion of the left coronary and right coronary because of the rheumatic pathology. The commissure is fused. So we discussed with the surgeon, and you can see here that this commissure is fused. The regurgitation jet is in between these two cusps. So we discussed with the surgeon. They did the commissurotomy to this patient, and then they found the opening of the cusp. And in post-operative, you can see that the cuspal movement there is hardly any AR in these patients. So this commissurotomy could be done when we could identify which commissure is restricted. Now, to the end of a topic, when everything is done, when we are discontinuing CBP, we are not waiting for our result after coming of bypass like mitral valve. We start looking at the rewarming phase. When the perfusionist, they say that there is a lot of venting, the venting is there from the LV. LV root is collecting a lot of return from the LV, then we can say there is a significant aortic regurgitation. So when there is a more than 300 ml aortic root venting is there, with the communication with the perfusionist, then we can say that this is definitely an issue of the persistent or continuing AR. All these topic is for the surgeon community or those who are seeing the patient cardiologist looking in the intraoperative. So second important point, so the LV dilatations in in the short axis view, transgastric short axis view, you can see the LV dilatations. You can put a color flow metric before coming off bypass. If there is significant AR, you will see the definitely AR jet. So our assessment starts not only after coming off bypass, but AR jet, dilatation of left ventricle or venting, which is more than 300 ml, should alarm that this patient can have a very significant aortic regurgitation. Here, in a lower bottom middle LV, where you had patient with LV, sometimes patient throw VTVF while coming off bypass, and this could be one of the indications that there is a significant dilatation of a left ventricle. So when you have a VTVF throwing at the time of rewarming, then you should be very careful. Another thing is you have the patients with a lot of air inside the left ventricle. So it is very important that you look for the air venting is again important for looking at. So our program, our assessment starts from the rewarming stage, and then it comes with the after rewarming. Now, after coming off bypass, if everything is well, when we come off bypass, wait for 5 to 2 minutes to settle the left ventricle, contractility, and then start assessing it. These are the 4 views: deep transgastric views and transgastric view. This is the right bottom is deep transgastric, and the left side upper is a if it's a transgastric view, and the mid is a long axis view. These 3 views are important views for assessment of regurgitation regurgitations. Here you can say that patient is in tachycardia. In this tachycardia also you cannot view the regurgitation very well, so wait for some time. So what you need to assess, once everything is stable, first you see the assessment of the annular height. How the annular height, if it is more than 24-25 size, usually this is the largest side. What we accept about 21 to 22 millimeter of the size of annulus. For in Indian populations, that is an adequate size, and that also depends on the size of the root, the size of the graft they put it. If usually the size of annulus is nearly 20% lesser the size of the graft they have put it. So if it is 26 size they have used, then about 20 to 21 annulus is good. So assessment is very important. Second important thing is look at the sinuses, and third is look at the coaptations. So the tip of the coaptation should reach to the midpoint of the sinuses. That is again very, very important. So when the coaptation heights, the tip of the coaptation should pass to the mid part of the sinuses, means that you have adequate coaptation surface into the aortic groove. So along with the coaptation height, which should be more than 4 to 5 millimeters, the tip of the coaptation should reach at the level of mid sinuses, and that is again a very important point. So can we predict recurrence of the AR? Yes. So basically, if the coaptation is not reaching to the mid part of the sinuses, then it should give a question that whether this valve will be okay or not. And there has to be adequate reserve. There should be adequate coaptation, should be more than 4 to 5 millimeters of coaptation height. And third important thing is the coaptation should usually be at the level of free margin, not at the body. If you look at this aortic valve, you can see the base of the leaflets are touching each other, but the tip of the leaflets are not touching each other. So the coaptation should not be at the body of the leaflets, but it should be at the complete coaptation surface. So these are the very important criteria to look for the repair or not. Now, this is a mild AR, but it is an eccentric AR. Patient can have the mild AR with the central AR, and patient have the mild AR with the eccentric AR. Remember that any AR which is eccentric should really alarm us to do something and recomplete and go on bypass. If it is a central AR, we can still accept it because the pathology of eccentric AR can worsen after patient in a prolonged period of time. So the tips of coaptation height, mid height level of the sinuses should be there. Effective height should be more than 9 millimeters. Coaptation length more than 4 millimeters. There should be no residual AR. That is very important. It should be less than mild AR in any case, and there has to be good valvular opening. So when AVR is not optimal, should we go for on bypass and reed clamping? So very important thing to be seen whether patient has got residual AR with eccentric jet or residual AR with the central jet. So residual AR, central AR is acceptable if it is not more than tribal. So central AR less than mild is very important, very easily acceptable because ultimately all the 3 cusps are joining together very well. So when there is a limited, when there is a central AR, when there is a mild central AR, it means that there is a limited extension of the color Doppler jet in the LV outflow tract. So when you have the central AR which is not reaching beyond the LVOT and not reaching to the mitral valve leaflet level or to the left ventricle cavity, it is a mild AR. When a contractor size is less than 2 millimeter and ERO, which usually may be a little difficult for the surgeon, but for the surgeon, if they look at the LV, when the central AR is reaching beyond LVOT, then they should alarm and if the vena contracta is more than 2 to 3 millimeters, it should alarm them for considering. So to begin to end with it, when they have the AR with this eccentric jet and more than trivial, that is more than mild, we should remember that this AR recurrence jet is very high, and always look for whether it is the same direction or opposite directions. If there is an eccentric AR, always look for the 3 possibilities. Either one of the cusp is restricted in the movement, another cusp is having a bigger height than the other cusp, or this patient has that, so these leaflets need resuspension, or if sometimes the restricted leaflet is there, then they may need to do something with the commissures. If there is a residual AR with a central jet, and if AR is less than grade 1, or that is a mild, means vena contracta is less than 3 millimeter, then this is acceptable and we do not need to go for the pump. But yes, mild to mild plus MR can be accepted in a pediatric populations where we cannot stick, because mild plus AR is less dangerous than patient goes for the metallic any metallic prosthesis or the bioprosthetic valve, which definitely needs redoing and other issues. But even in the eccentric AR, if the grade is more than 1, then and the vena contracta is more than 3, then either when there is eccentric AR, either then annulus is too large. As I said, annulus should be about 23, 24 maximum in our Indian scenario, or there may be a symmetrical restriction to the cusp. So when you have more than mild AR and the patient has got the central AR, then again look for the annulus size and look for the cuspal height. That is very important. So basically, when we look at the post-operative phase, it is very important you communicate with the surgeons and be attentive intraoperative period, where you can continuously discuss with the surgeons about the pathologies, about the other problems where they are facing, so we can always anticipate where the problem lies. Sometimes surgeon discusses with us that RCC was very narrow, they did application to increase the height. So all this thing is very important when we keep communicating with the surgeon during the procedure. So to conclude, aortic repair is very important, but it is very important to look at the aortic growth, cuspal anatomies, cuspal pathologies, mechanism of AR, and communication with the surgeon is very important. Communication with the perfusion is also important when you are rewarming the patients. This all indicates that how the repair thing is going on. With definitely the outcome of repair is not as good as what we look in the mitral valve, because mitral valve is still a low flow area. In the aortic valve, why it is not good to accept more than mild? Because these are the high pressure jet areas, and these patients can have the bad high recurrence rate in a short while. So thank you very much for the listening to me, and hand over to our moderator, Dr. Prasanna Sinha. Thank you very much.
Hello, can you hear?
Yes, sir, you're audible.
Yeah. Okay, that was a fantastic talk, Dr. Naman, and we always learn something new every day, and I enjoyed your talk thoroughly, and I'm sure the rest of the crowd has enjoyed, and we are seeing a lot of comments. Now, before we open the questions for which have been posted here, I've got a few questions for you. Now, one of the problems that I have been facing...
That worries me more.
Pardon me?
That worries me more. You have a question.
Now, I have some questions for you. And one of the things that we've seen, which we find difficult to assess by echocardiography, is our stress fenestrations within the lunule of the leaflet. We find that there is no AR in that region. It is not, because it is in the lunule, it does not leak there. But when we open up, we find that. And unfortunately, it seems to be missed. Do you have any tips and tricks to detect this? Because this is one of the things which becomes a contraindication to repair or makes the repair extremely difficult.
So if I am understanding your question, that the fenestration of the aortic cusp is missed sometimes.
No, it is in the zone of coarctation, that is in the lunule. But it is difficult then to repair, because the leaflet there is very tenuous.
So basically at the tip of all the three cusps meeting each other. Yeah, that's very easy. That's very good question, sir. The thing is, we have to have assessment in the zoom mode. Like we always do it whenever we assess the structure analysis in the midst of the long axis view or short axis view, we create a zoom mode where a complete screen of the echocardiography is filled with that particular aortic valve, whether in whichever the view we see it. Forget we are not dealing with the 3D echo images, but even the 2D echo images, definitely even the minute AR can be seen either in the biplane mode. So what we do anyway, if we have the 3D echo machines, we do the biplane way, means one is reference is in aortic short axis view, another is long axis view. In a zoom mode, if you put the color, even the minute of the regurgitation cat can be easily seen. And once which is not easily seen, if we just leave it alone, then I don't think that will give any bigger issues in the outcome also. But the zoom mode is very important in this minute assessments.
Thank you. Another question which I have is one of the points which I have seen useful is to see where the coarctation line is in relation to the annulus at the end of the repair, not just the tip. But if there is a sagging of the coarctation line below the annulus, what are your viewpoints on that? Because I think that happens, we are not going to have a good result in the long term.
Yeah, absolutely, very well taken point, sir. Usually when you have the, suppose example, when the RCC is sagging, or RCC and the NCC and LCC has a bigger height than the RCC, this will happen that it will just compress the RCC, and RCC is very small. The coarctation border is going towards more over the anterior part, basically. And this happens, the associated finding which I really missed to say, that when the sagging, the base of the coarctation, the base of the body of a leaflet, if it reaches to the level of annulus or beyond to the alveoli. So when we do in the, I'll just share the important image to this to put it in a better way. I'll just share it, this image. So here, if you put an annulus, like this is what you are exactly talking, where you have the coarctation line is not exactly at the center. But so what we see here in this case, when you draw an annulus, the part of a body of a leaflet is sagging towards the alveoli. This is always happened when the coarctation is not at the center. So when you draw an annulus and the part of the body is falling in the alveoli, and this is a place, this is a time where you are not sure that this AR is going to come back again or not. And usually we find that these patients will have definitely some residual AR. So basically, as you said correctly, that you have to see the body of the aortic leaflet, which should not cross beyond the aortic annulus toward the alveoli. And when the coarctation line is not exactly at the center of the aortic annulus, then definitely the chances of repair, because all the three cusps are not at the same plane. It means that. So the regurgitation is very high.
Now I have one technical question on transesophageal echo. And that is sometimes when we have extremes of left ventricular hypertrophy and dilatation, and even if you have a large LA, for example, if there's aortic and mitral repairs going on, I find it difficult to align the transgastric view at the end of surgery to assess the. Do you have any tips and tricks to help in aligning?
Yes, absolutely, sir. What happens, I'll tell you, three problems lies when you are checking the patients in post-repair, and few problems when you are checking the patients in pre-repair. When you have a lot of issues, first of all, in such cases, better to put a Ryle's tube and aspirate the gastric content, aspirates the air into the stomach, so that will make the complete stomach empty. Second and very important thing is, when you are getting any problems in aligning the deep transgastric view, then at least transgastric view, long axis view will definitely see. So either of these we will definitely see. If you are not able to see the deep transgastric view, the transgastric long axis view will definitely see. And all my colleagues and we have made it a rule that transgastric view is very, very easy to see as compared to deep transgastric. Another problem is when you are putting the probe, it is always better to remove the dry strip and then put the probe well into the stomach. Now, there is a trick for assessing the deep transgastric, means put the probe right down into the middle part of the stomach, extend it, flex it, and go gradually coming up, go gradually withdrawing up. And then once you start the mitral leaflets, and that is the time when now the chances are that you will start seeing the aortic valve. So in that time, you should be very careful. But important thing, gastric content and air has to be sucked, because we are putting the probe in the gas. So the gas will, or the fluid in the stomach will definitely have some influence on the outcome. That's what I can say. But yeah, many of the times deep transgastric is difficult. So transgastric long axis will be always lie upon.
Another thing is that I don't do remodeling, I do reimplantation. And anyway, whether it is remodeling or reimplantation, but especially in reimplantation, I have one issue. Sometimes you get RV dysfunction. This could be due to the RCA kinking, or it could be due to air and other things. So we would like to see the flow in the right coronary artery. And sometimes it's difficult to see immediately. The left, usually you can see the flow in the left coronary artery well, but the right sometimes is difficult to visualize, especially if the coronary implantation has been high. What are your tips and tricks for that?
Yeah, actually very well. Our questions, usually in our all the repair and the Bengal procedures, we have a protocol that we always look at the coronary arteries. And you said, as you said correctly, left coronary artery is very, very easy to be seen. Very easy, like you see the tricuspid valve and you just withdraw a little bit probe, you will see it. But usually you graph the right coronary artery definitely much higher than the left coronary artery. So the long axis view, the mid-esophageal long axis view is the best view to see for the coronary side, not the not the short axis view. Because in short axis view, you hardly see this right coronary artery. So the long axis view, and that is when we see the long axis view, it is about first you look at the annulus, then you see where the right coronary cusp is ending, and then you see the 1 to 2 millimeter area, and then turn the probe in a counterclockwise or clockwise with the color flow there in place, and that color flow with a very low gain. When you want to check the color flow into the coronary artery, it is very important we keep the color flow gain in the very minimal, so even the minute of the flow into the right coronary artery can be seen very well. So better to have it in the long axis view, doing the annulus, end of the cusp to 1 to 2 millimeter in that low, reduce the grain to about say 20-30, and then put in just change the probe the clockwise or counterclockwise, because it changes its orientations, because you are not as exactly placing in the right up where you had the right coronary artery. So this is a view what commonly you see, and definitely as you said, RV dysfunction is very common if there is a kinking, a problem in the right coronary artery. So this is important thing.
One more question that I have is, you were mentioning about repairs and calcification. I have had bad experiences with even minimal calcification. You may get what may appear to be an excellent result, but in my practice, I virtually have stopped decalcifying these valves. And if you go back in literature and to say that history repeats itself, Senning had done a lot of decalcifications in his initial experience, and he later on found that these results are not good. So what is your opinion? I mean, what is your opinion? I tend not to do it.
Yes, actually the aortic valve failure program initiated collapse because of the calcific aortic leaflets and aortic cusp. And you said very correctly that when you have the more than grade 3 calcification, it is not right leaflets. If you have the one leaflet calcifications with a small calcification nodules onto it, still you can take a chance. But definitely for the heavy calcification grade and more 3, we never ever go for the repair. Couple of reasons behind it is the durability and the elasticity of the leaflet is not there. Whatever the coaptations will not have the better surfaces. It will not have the good curvature to have the better coaplant surfaces. It will restrict by whatever you do it. And third important point is there are a lot of other calcifications to the annulus, aortometal continuity, and everything lies to that. So whenever you have the more than moderate calcifications, we should never progress to the aortic valve repair. Yes, calcification is one of the very important relative contraindications for aortic repair.
One last point which I would like to discuss with you is I make it a rule in my echocardiographic assessment post-operatively because of one case where everything looked good, but we had reversal in the descending thoracic aorta at the end of surgery. We just could not find the AR jet, whatever, but then I had to go back in and re-repair that valve. So what, have you had such an experience? Because we interrogated in short axis, long axis, everywhere, and whatever the leak was, it wasn't really looking bad. It was looking very, very small. But I said no. What is your thought on that?
Sir, when we see the reversal flow into the descending aorta, I mean, it is grade 4 AR, significant AR. So three things happen with significant AR, that when you are rewarming, this left ventricle has to dilate. Because when there is a reversal of flow in the descending aorta, there has to be significant return back to the left ventricle, and left ventricle has to be dilated. So in the rewarming, we always look at the dilatation of the left ventricle is one of the important fact. Second thing is, in such cases, before coming of bypass, in the rewarming stage only we look at the regurgitation jets rather than wait for the coming of bypass. And third thing is, we always discuss with the perfusionist how much return they get to the left ventricle aortic return. And if they say more than 300 ml, then even we look at 300 to 400 ml, even we see the significant AR jet or not, dilatation or not, that we always believe that there has to be a significant aortic. But when you have the reversal of a jet, definitely it tells you that it is a significant AR in such cases. I don't know why you could not see in the short and long axis view. It is a big surprise to me, actually.
Yes, that was also very surprising for us. But
sometimes the tachycardia can be one of the reasons why you underestimate the regurgitation jet. That could be one of the reasons, actually.
And I mean, there have been some questions, and a lot of people seem to be asking one question, and they want clarification of the aortic root from you. What is I think there are at least 20 to 30 people all asking for clarification of what is the aortic root, the sinus, and the ratios. Could you just tell this to the viewers once again, because that seems to be one question.
So I go back to the presentations. Should I go with the presentations with your permission?
Yes, please. While this is being put up, one small point that I wanted to make is that in pediatric, because I do a lot of pediatric aortic valve repair, so we cannot use 300, 500 ml, but we take what Dr. Tendulkar used to teach us, that is 10% of the pump output. You should never have more than 10% of the pump output in the event.
That's very important, sir. That's very important. So I'll start with I'll just skip the annulus, which everyone knows. So this is like the geometric assessment. This is the geometric measurement assessment of the aortic root, and that has to be done even in the transthoracic preoperative assessment as well. This is not only the intraoperative assessment, but this is also the preoperative assessments in the transthoracic echocardiography when we do it. So here the annulus, as I said, where there is a hinge point to hinge point is the annulus diameter. And usually you have the aortic regurgitation, and the annulus is considered to be dilated when you have the annulus size beyond 26, beyond 25 to 26. So this is in Indian populations, the annular diameters beyond 25 to 26 is considered to be a significantly dilated annulus. Second level we have to consider that the geometric height of the root, the geometric height of the cusp. Now, when we talk about the geometric height of the cusp lies in all the three cusps. Geometric height should be measured. It is not only the one cusp. So we have to see all the three cusps in the long axis one by one. So here your geometric height, you can see here that it starts from the hinge point of the aortic wall to the cusp. So here you can, what you can see that here you can see this is the geometric height, the first height which we measure from the hinge point of aortic wall to the coaptation surface, and from the coaptation surface to the tip of coaptations, that is the geometric height, and that decides how much tissue you have for your repair. That should be more than 16 millimeters in case of tri-leaflet valve and 19 millimeters in case of the bi-leaflets. This is a geometric height addition, so height from the hinge to the coaptation plus height of the coaptation surface to the coaptation tip. Second is the effective height. The effective height is only one height. Like geometric height, you don't have to go to all the cusp. The effective height, it is from the annulus to the tip of the coaptations. This complete effective height should be at least 9 millimeters. Out of these 9 millimeters, the cuspal height, the coaptation height is 4 millimeter, and the distance from the annulus to the coaptation point. So if I just put it like this, so I put it like this, the distance from the annulus, you can see here the distance from the annulus. So distance from the annulus to the coaptation complete is about 5 millimeters, and the coaptation is about 4 millimeters. So effective height is become 9 millimeter here. So when we call it the effective height, its effective height is about 9 millimeters. So this is the 9 millimeter. Out of 9 millimeter, the coaptation height is about say 4 millimeters, and the annulus, from the annulus to the coaptation is about 5 millimeters. So these are the substance. This is a leaflet deformity indices. This is a leaflet geometry which we need to explain to the surgeon. The annulus is 25 millimeters or 26 millimeters from the hinge point to hinge point. Then it should be from the annulus to the tip of the coaptations. Then you have to see the geometric height from the hinge point to the complete length from the coaptation to the tip of the coaptations. So the effective height tells us the area available for the leaflets, and the geometric height is the area available with us, the surgeon. So effective height should be about
Okay, I checked. The yellow.
Hello, can you hear me?
So here when we have the regurgitation, you can see that one of the leaflets, the RCC is prolapsing into the completely into the alveoli, and if you put your annulus marker, the part of the RCC is just falling into the left ventricle. So this is effective orifice area. So basically, when you have the effective orifice area is from the annulus to the coaptation, it becomes negative. As I said, it should be 9 millimeter. So this is 9 millimeters of. So this is the effective orifice area. If it is less than 9 millimeter, if it is less than 6 millimeter, it should definitely indicate that definitely cusp prolapse is there. So this is how you measure the effective orifice area. Now, when we talk about the, this is how we measure the effective height. Now, when we talk about the geometric height is distance between from the hinge point. So from the hinge point to the coaptation surface, and that should be the 16 millimeters in the tri-leaflets valve and 19 millimeters for the bicuspid leaflets. So this is how we measure the geometric height. So if we have the leaflet which is restricted, so effective leaflets is meant, the measurement of effective height is for the prolapsing leaflet, and the measurement of the geometric height is for the restricted leaflet. So how here, like we measure the one height from the coaptation surface to the hinge of a leaflet, and other height is a complete coaptation height. These two height addition is called as the geometric leaflet. And if it is less than 16 millimeters, so we can discuss with the surgeon that sorry boss, your height is not good, which you will be not be able to have a good cuspal height. So second is the valvular pathology, like no calcifications, mild calcific, moderately calcific, and heavily calcific. So if you have, sir has correctly said that if you have multiple large spot of the calcium on the leaflet, then they are not the best route for the assessments. Like what you are seeing here, there are very bad calcific plaques seen on all the three leaflets, and you can see that leads to the definitely restrictions of the leaflets. So number of leaflets, but degree of leaflet calcifications plays important role in a long-term success of the aortic root. And if it is more than moderate leaflet, so the scoring should be less than 3, means there should not be the large, moderate, large calcifying dots seen in the leaflets, then it is not the base leaflets for the repair. Now you have to measure the cusp thickening also. If it is more than 2 millimeter, then we can say this cusp has to be restricted, whatever we should see in the echocardiography. Now, one important aspect about the measurements, I'll just tell you. Now, when we assess, the view. So when we want to measure the diameter, there is a bit confusion whether what diameter we should measure. Usually on the aortic side, we should, what guidelines say, leading edge to leading edge, and what left ventricle side diameters, what they said that inner edge to inner edge. It means that leading edge means the outer surface, outer border of the aortic wall to the inner border of the aortic wall, that is called the leading edge to leading edge. So when we want to measure the diameter on the aortic side, that is aortic root diameter, whether we talk about the sinuses, sinotubular junctions, or the ascending aorta, then all the diameters should be measured in the end diastolic. Very important. All the diameters should be measured in the end diastolic when we measure diameter in the aortic root side. So again, in aortic root side, all the diameters should be measured in end diastolic. Guideline says leading edge to leading edge. Leading edge means outer border of the aorta to the inner border of the aorta of other side. But in practically our practice, we only measure inner edge to inner edge in all the places without creating one confusion. If it is significantly, we will definitely give it a significance. And all the diameter of the ascending root should be measured in end diastole. Now for the annular assessments or left ventricle outflow tract assessment should be measured in the mid systole. They should never, because these are the two phases where the size is maximum. So when we measure the diameter of an aortic annulus, should be measured in the mid systole number 1 and should be inner edge to inner edge. And this thing is very important for understanding, because if you change the phase of the cycle, then probably you may not give a very good results. Any more suggestions, sir?
Yeah, you have given such a erudite explanation. There can be no questions on that. Now another question which has come is, if the patient has concomitant mitral valve disease, for example, he has got MS, and one specific question is assessment of the need for aortic valve procedures in the presence of mitral valve disease. For example, severe MS, how do you assess the aortic valve, whether we should intervene or not?
Yeah, very important questions, because in a rheumatic pathology or in other pathology, when one valve is very badly affected, definitely the another valve has got definitely infusions. Like suppose in a view of the mitral stenosis, the aortic regurgitation jet may be underestimate. Severe MR will also influence the AR degree. So definitely one valve will have definitely the influence of the other valve. And in that case, again, the structural assessment plays a very important role, because like as I said, in intraoperative phase, the structural assessment, like in one of the cases which I have shown, that patient was referred for the mitral valve replacement, and the patient had moderate AR, which was seen very well. So in that case, the commissurotomy is possible. So we did with the commissurotomy. But if patient has got moderate, patient has got one mitral replacement, which is mandatory, and then replaced with metallic prosthesis, and usually we do not, if we have the mild to moderate disease in the aortic valve, we usually don't become more aggressive in repair, or we try to replace that valve, because as such patient is taking anticoagulants for the mitral valve, and this aortic valve may come in very short future. So it's significantly affected valve. With the mitral assessments, we all replace the aortic valve if we are replacing the mitral valve. Now, if we are repairing the mitral valve, then our target is more in favor of aortic repair. And that time, the regurgitations, quantifications plays an important role. In that case, any AR in presence of the other valve, any AR, if more than mild, should be repaired or replaced in perioperative period, irrespective of what, because these patients, this patient had come for the mitral valve, any grade of the more than mild AR or grade of mild AS, if patient has got aortic gradient of more than 25 to 26, these patients should definitely be addressed with the aortic valve. Now the issue with the gradations, what influence makes between the mitral valve assessment and aortic valve assessments. Usually you should assess all these things in a pre-operative period, because intraoperative, in anesthesia period by itself, the inotropes, vasopressors, the volume infusions, the vasodilatation stage of the anesthesia, all this underestimate the aortic valve. So in preoperative transthoracic, even the moderate AR is seen, can be seen the mild AR, and surgeons say, okay, in mild AR we don't want to do anything. So all the assessment should be done into the preoperative period when you are taking decisions to grade another aortic valve. Now for the aortic stenosis, in the presence of aortic stenosis, when you are taking for one surgery, mitral valve, you have become little liberal in taking decision for the intervention for the other one, because patient is as such coming for the table. It's not only it's not only medical management, right? And patient is coming already for the surgery. Our gradations for the intervention is becoming little liberal. So any grade in any associated valve, if it is more than 25 to 30, we always try to address as aortic valve. Any gradations in the associated valve, if it is more than mild, definitely we address this valve, whether we repair or replacements. And which is the best techniques for it? For the aortic valve, planimetry is not the best techniques in the view of the calcific aortic valve, because there are a lot of calciums. They may not give you the right idea. So in this case, pressure half time maybe sometimes gives a good idea. But in pressure half time, if you have associated significant mitral regurgitations, then you have significant pressure regurgitations, pressure half time will be affected. So preoperatively look at the structural assessments, and anything beyond moderate with any view, you should definitely address this patient in intraoperative period.
Yeah. Now, one question that they have asked is acommissural aortic valves. They wanted to know something about it.
Acommissural means which?
I presume they're telling unicuspid valve without, which is pseudo acommissural.
So it's basically a unicuspid. If you talk about unicuspid valve, we have seen that many times we have referred the patient for being a bicuspid valve. In intraoperative, yes, we found it is a unicuspid or monocuspid. And as compared to the publications, our numbers of being a monocuspid or unicuspid is very, very high. We see plenty of unicuspid valve. So repairability in unicuspid valve is very, very less, because we do not have any other commissure lies with it. And whatever the single commissure is that which works as an opening, that itself becomes calcific. So once or twice we have tried, we have been successful in repairing only once. But from monocuspid, we have to make a bicuspid aortic valve, and we have to make the other separate commissures in just opposite to that open commissures. But again, it is very difficult, because that part is again very calcific, very fibrous, and the cooperation margin is not very well accepted. So basically, repairing the unicuspid or monocuspid valve is not very, very good at all. I don't know what is your experience, sir.
It is same because I prefer to do a orthopericardial reconstruction in these where it becomes very difficult. Another question which has been asked multiple times is your assessment in cases of VSD-AR.
VSD-AR, yes, you are talking about more in the pediatric populations, because there is many of the times there is a cushion defect, there is a perimembranous septum which is deficit, the aortic regurgitation, that there is suspension, there is a suspension of the right coronary cusp which suspend downstairs, and then that leads to the prolapse of the right coronary cusp. So that is again moreover in the preoperative transthoracic image, that image we see. And when we see the very significant prolapse, the significant prolapse means the effective height should be less than 6 millimeters from the level of the annulus. And if we see such, then definitely we go little more aggressive in discussing with the surgeon for the aortic valve repair. And in aortic valve repair, they put a patch in such a way that it covers the VSD as well as that gives a little support to lift up the right coronary cusp. And so basically, if effective height, whenever we talk about the prolapsing, we have to look at the effective height. Now in pediatric populations, you may not have a 6 millimeter prolapsing height. So in that population, if we can say that, in other way I can say that if the body of the leaflet is protruding towards the left ventricle outlet tract, look at the body of RCC, if it is protruding into the left ventricle outlet tract, this valve has to be repaired in intraoperative when you are repairing a VSD. So if in a small pediatric population, this effective height is not very best way, but look at the cuspal body. If the cuspal body is protruding beyond the annulus into the left ventricle outlet tract, then definitely we have to discuss with the surgeon that they put it when they do the VSD in such a way that it gives a support to the RCC from the beneath. Your point, sir?
Yeah, I fully agree with you because actually a large part of my practice, because I do a lot of pediatric repairs, is actually VSD-AR. And we are even doing repairs consistently even for severe AR. The only time we are not able to do it is when there is a frank destruction of the leaflets. Otherwise, most of the time we are able to repair these valves, even in the presence of severe AR. They may be a little complex repairs, but they are doable. But people should concentrate on doing those and it can be done and with gratifying results. We had presented in PCSI last time around 50 consecutive VSD AR repairs. And one small point I would like to add is that one of the things that we have seen is actually iatrogenic VSD AR, VSD closure, where people have damaged the aortic valve and have had to take down the VSD patch, repair the tear in the aortic valve, re-repair the aortic valve and do the patch. So that's not so often, but we get such references to, but that's an unusual thing that we also see. I think we have covered most of the questions which have been asked, and I found your lecture very inspiring and very detailed, and you've got beautiful images, and it is something which all people who are doing echocardiography for aortic valve repairs would aspire to, and they should give such excellent images as you have given. And I thoroughly enjoyed your presentation, and I'm sure, and seeing the comments in the chat section, that everyone has enjoyed and they have thoroughly loved your presentation. And it's been a great time. And I'm thankful also for Philips to have made an arrangement for such an excellent discussion with such an excellent speaker, and we've all enjoyed it. I'll hand over the, are there any other comments that Dr. Naman would like to make?
Yeah, thank you very much, sir. And I would really thank you on behalf of me and the Philips for being there. We have already, we always hear your lectures on the CPP, the problems with the CPP, and so many like in your ISCTS webinars. And thank you very much for giving good comments, and thanks Philips, and over to